So thank you very much for inviting me to speak today. On the flyer, the title of this meeting is, and Michael just reiterated it, it's Living to 120 and Thriving. The title of my talk is, Don't Just Do Something, Sit There, When Less is More in Seniors' Health. And I've chosen to talk about this because in my 33 years of working as a family doctor, I am increasingly aware of the harms that can befall seniors in their encounters with our well-intentioned healthcare system. But first I want to talk about what healthcare can do. So this is a slide that is the change in life expectancy of Canadians. And as you can see, from 1921 to 2008, our life expectancy has gone up and up. So for males, the average life expectancy in 2008 is 79, and for females it's 83. It's about, on average, together combined, just over 81 years. And BC actually is higher than that. BC has the longest life expectancy of all the provinces. Must be all those mountains and fresh air or something. So 45 years ago, when a patient suffered a heart attack, apart from providing a few nitroglycerin pills, there was very little we could offer them. Today, by contrast, we still prescribe nitroglycerin pills for heart pain, or now it's the nitro spray, but now we also prescribe pills to lower cholesterol. Probably many of you are familiar with the statins. How many people know about the statins here? Yes, lots of hands go up. Pills to relax the heart. These are also known as the beta blockers. Pills to lower the blood pressure. And a blood thinner, usually aspirin. We actually now assign quality ratings to hospitals who send patients home after their heart attacks if they start their patients on these medications. And that's just the medicine side of treating heart disease. When someone has a heart attack today, we now also, in many cases, are able to thread a tube into the artery that's blocked and open it up so that the blood supply to the heart muscle is restored. And in Canada, we've more than doubled the rate of doing this procedure since 1994. We can also offer a more extensive surgery to graft a new artery to replace the old blocked up one. And for those with heart disease, these pills work, both to extend the duration of life and in many cases to maintain or restore people's function. And these procedures likewise work well. Likewise, worn out hips and knees. 20 years ago, all we could do is offer patients with bad arthritis of the hips and knees painkillers and a cane, maybe the right size cane, but just a cane and a walker. Now medical science can replace these parts pretty easily and safely, and in many cases with good success. In British Columbia in 2010, we performed over 6,000 hip replacement surgeries and 7,000 knee replacement surgeries, and we're doing more of these surgeries every year. So these are just a few examples of the amazing advances in medical technology that we've been producing to fix things that go wrong with our bodies. Now, these technologies and medicines often work well for middle-aged adults and for seniors who aren't frail. But for seniors who are frail, they may not offer the same benefit. So what do we mean by frail? So we probably all have a gut sense of what the word frailty means. The geriatricians define it as a loss of energy, a loss of physical ability, a loss of cognition, a loss of the ability to think and remember things, and a loss of general health that in total makes someone more vulnerable, more fragile. So when we think about the frail people in our lives, they may not be able to get around so well. They may not think or remember so well. And it's harder for them to carry on some of the basic activities of daily living, like shopping or banking, or in some cases, even washing and eating without getting assistance. I'm sure that all of you know friends and colleagues who are frail. For doctors and other healthcare types who work with seniors a lot, we actually have a way of classifying frailty. And as you can see by this slide, there's mildly frail people, and then there's moderately frail, where they need some help getting around, and then there's very severely frail people. Mildly frail seniors need a little bit of help to do a few things. Moderately frail seniors need a lot of help. And a severely frail person is entirely dependent on others for almost everything. Now, the important thing about frailty is we can actually give somewhat of a prognosis. Very much like we can give a prognosis for various types of cancer. So the chances of someone with very severe frailty surviving past 6 years is less than 40%. And about a half of those people will require nursing home care in that time. Does everybody recognize this magazine? So the header is, can we stop aging? And then the subheader is, there are scientists who believe we can, but would we really want to? So there's two little-known secrets about modern medicine. The first is that doctors can give you a new hip, a new knee, we can open up blockages of the arteries, and treat cancers in various parts of the body. But modern medicine does not know how to stop people from becoming frail. In fact, precisely because of the successes of modern medicine, we see people living longer as they survive their various chronic conditions, they get their new body parts, and the longer a person lives, the more likely they are to become frail. There are no drugs or surgeries to prevent frailty. So far, the only thing we know of to help reduce frailty is exercise, staying active. Pretty low-tech solution for 2013 with all our bells and whistles. And once a senior is already very frail, even exercise doesn't really change things. At a cellular level, the cells in our body are constantly regenerating. And there's a little part on the chromosome that controls this, and that's called the telomere. And over our lifetime, this telomere gradually gets shorter and shorter until eventually the cell stops dividing and regenerating anymore. And science so far hasn't figured out how to stop those telomeres from getting shorter. Now, in large Canadian surveys, most seniors between the ages of 65 and 75 are not frail. In fact, if you do surveys, they report the same number of limitations in their activities of daily living as adults aged 45 to 64. But by the time a senior reaches 86, about 1 in 3 people report that they do need some help with their activities of daily living. In other words, if you live into your mid-80s, you're likely to have some degree of frailty. So that's the first little-known secret. The second little-known secret of modern medicine is that we don't really know how to properly care for frail people. When a frail person enters the hospital system, the doctors simply do what they're trained to do, which is try to fix each individual disease or broken down part with our medicines, our surgeries, and our well-memorized algorithms that work great for adults and seniors who aren't frail, but can be a disaster for those who are. So for frail seniors, more is often less. What do I mean by that? Well, let's take hip surgery as one example. When a senior undergoes hip surgery, approximately 1 in 5 will develop something called post-surgery delirium. How many of you have heard of the word delirium? Yes, oh, lots of hands, even more than the statin question. So delirium is a condition where a person becomes disoriented and confused, and in plain language terms seems completely out of it. They may appear to be seeing things, they're easily distracted. We don't really know why people develop delirium after surgery, but it's likely due to a combination of the anesthetic and the physical stress of the surgery. You can tell if someone's delirious because they may look great in the morning, and then by evening they're talking nonsense and picking at things in the air, and then the next morning they look great again. So it fluctuates, it goes up and down in the course of a given day, and it usually does clear over time. However, the thing about delirium is that even a long time after it's cleared and the patient's left the hospital, over about a half of those who developed delirium continued to have problems with memory. Frail seniors, and especially seniors who had some thinking and memory problems before the surgery, are much more likely to get delirium. And they're 5 times more likely to need nursing home care within 3 years of their surgery. So for a senior who's very frail and who has hip arthritis, this is very important information to consider before opting to get a new hip. Another example of when it's important to consider frailty is how we doctors treat diabetes. Now, there's medical guidelines for treating diabetes that call for keeping the blood sugar within certain limits, because there's some evidence, if we do that, some of the long-term effects of having diabetes may be prevented or delayed. Now, these guidelines are drummed into our heads in medical school and at our professional development conferences. In many places, including BC, doctors are actually given bonuses if they show they're following the guidelines. But for frail people, the same rules for diabetes don't apply. We now know that if a person is frail and their blood sugars are too well controlled, this can result in the sugars running low, which can cause long-term harm to the brain. Also, a frail person is way less likely to recognize if their sugar's low. You or I might get sweaty or feel faint, whereas a frail person may not even recognize they have a problem. So using the standard guidelines for diabetes can be quite harmful to a senior who's frail. The same thing for treating blood pressure. The targets we apply to younger seniors and adults aren't the same as those we apply or should be applying to seniors who are old or frail. These folks generally need their blood pressure to be higher. In fact, one study found that seniors over 90 with high blood pressure, according to the standard guidelines, had a longer survival time compared to those with so-called normal blood pressure. So many of the rules based on scientific evidence that guide our practice in medicine don't apply to frail seniors. Unfortunately, when frail people end up in hospital, often the only way the system knows how to treat them is as if they aren't frail. Our specialists are trained to deal with one problem at a time, and our scientific knowledge comes from research on people who aren't frail. All the research and clinical trials on which we doctors base our decision-making deliberately excludes frail people. So when faced with caring for a senior with multiple medical problems, we often don't even consider whether a person is frail. Doing this takes time and careful information gathering. And doctors are poorly trained to even look for it, to have it on their radar. So we just proceed as if someone isn't frail. We apply our medical decision rules and algorithms for each specific disease to that person, and in doing so, we fail to see the forest for the trees. We consider the body parts and individual diseases, but not the whole person. We focus on fixing what's broke using tools in our toolbox that worked well for younger people who aren't frail. After all, this is what we're trained to do. And that's how Mrs. Jones ended up on 16 prescribed medications. I introduce you to Mrs. Jones. She has diabetes and arthritis. She had a heart attack about 10 years ago and her kidneys aren't working too well. Her memory isn't great. It's hard for her to remember what she had for dinner the night before, but she still remembers the name of her children and her grandchildren. Her husband takes care of the shopping and banking, so she's kind of moderately to severely frail. Her diabetes, this is a math challenge here. You got to start counting up the meds. Her diabetes doctor prescribed 2 medications to control her diabetes, and after her heart attack, her cardiologist put her on 4 other pills to reduce her chances of getting another heart attack. One of the diabetes medications made her stomach upset, So the family doctor prescribed another pill to reduce the stomach acid. One of her heart medications and the calcium pill her arthritis doctors urged her to take for her bone was making her constipated. So she started taking a laxative pill. She's now up to 9 pills a day. Taking all those pills make her feel nauseated, she doesn't enjoy her food, she gets dehydrated, gets up one morning, feels dizzy, and falls. She gets taken to the emergency department, luckily doesn't have a fracture, but is badly bruised and in pain, so she started on 6 more pills for her pain. And of course they do tests at the hospital, and the lab tests find that she's got anemia, so the doctors prescribe some iron pills. Et voila, Mrs. Jones is on 16 pills a day and feels terrible. In 2001, 1 in 200 Canadian seniors ended up in hospital due to the side effects of pills. And the frequency of this occurring is going up every year by 3%. Seniors age 85 and older are almost twice as likely to experience this compared to younger seniors. And if you're taking over 10 medications, you're 4 times more likely to have some kind of bad reaction to a medication or the combination of those medications. As Michael said earlier, Dr. John Sloan has written a book about the importance of keeping seniors out of hospital. He describes seniors and hospital as a marriage made in hell. For each day a senior ends up in hospital and is confined to bed, they lose on average 1% of their muscle. Frail seniors in hospital are more likely to develop delirium, which we talked about earlier. They're more likely to get bed sores and to become frail, so they would then require nursing home care. Elliot Fisher is a very well-known health services researcher from the United States in Dartmouth. He looked at the differences in Medicare expenditures across the US and found that there were huge differences in how much care people were getting, simply depending on where they lived. He found that Medicare was spending $10,550 per person in Manhattan compared to $4,823 per person in Portland. And these differences weren't because people were older or sicker in Manhattan, or because things in New York cost more. They adjusted for all that, so they compared apples with apples. So why was Medicare spending more on Manhattan residents? Well, it turns out that Manhattan residents were twice as likely to spend time in the hospital, had twice as many visits to doctors per year, and during the last 6 months of their life, they were 3 times as likely compared to Portland residents to spend 1 week or more in intensive care, and had 5 times as many visits to a specialist. So Manhattan residents were getting more stuff done to them. So the question is, did all this extra care or stuff make a difference? Well, the same research also showed that Manhattan residents experienced a lower quality of care, lower levels of satisfaction, and for patients who had colon cancer, heart attacks, and hip fractures, the survival time was actually better for the Portland low-cost group. And residents were, patients who were getting less medical stuff done to them actually lived longer. So these are some examples about where more is less. Interestingly, there's also some very good research on when less is more. So we now have some interesting studies that show that when we provide care to someone with a serious illness who isn't expected to survive for very long, with care that is focused on improving that person's symptoms and quality of life, something we often call a palliative approach, those people are more likely to live longer than people with the same serious illness who don't receive this type of care. They also report better quality of life and less disability. So what can seniors do? Firstly, seniors can challenge us doctors. We need your help to see the forest when we're only looking at the trees. You need to make us look at the whole person when we offer up our fast-paced treatments and prescriptions. You need to say to us when we're rushing through our busy days, writing up a prescription or ordering a test, don't just do something, sit there, and challenge your doctor to consider these questions. Doesn't quite show there. These are 5 key questions I encourage you to ask your doctors each and every time you or your loved ones are making a healthcare decision in the years to come. Which health conditions are easily treatable and which aren't? How much frailty is there? How will frailty make treatment risky? How can symptoms be safely and effectively managed? Will the proposed treatment improve or worsen function? Will it improve or worsen memory? Will the proposed treatment allow more good quality years, especially at home? And what can we do to promote comfort and dignity in the time left? These questions are especially good to ask if a senior has some frailty, but I think they're pretty good questions to ask anytime. They were developed by 2 geriatricians in Halifax who developed something called the palliative and therapeutic harmonization approach. And these geriatricians have set up a clinic that provides consultation for frail seniors to help seniors decide with their families which treatments are likely to be useful and beneficial and which are likely to cause more harm. The second thing seniors can do is to challenge researchers to include seniors who are frail in their studies. In biomedical sciences, the most solid evidence to allow us to say that a drug works is something called a randomized controlled trial. In this type of a drug trial, participants are randomly assigned to an experimental group or a control group, and participants are blinded, so they're not told which group they're in. Then those in the treatment group are given the real treatment, and those in the control group are given the fake treatment or a placebo. Finally, the results of both groups are compared. Now, frail seniors are almost never included in these studies, so we have absolutely no scientific evidence about which treatments work for this group and which are likely to do more harm. We're really operating in a very large vacuum. We need your collective seniors' voice to push researchers to include frail seniors in these studies. Finally, we need seniors to challenge a system that's focused on high-tech hospital care, where even though lip service is paid to supporting seniors in the community, these services are constantly being reduced, fragmented, and reorganized. I see lots of nodding heads. Frail seniors have difficulty accessing home support. More access and instant access to home support has been shown to reduce the need for nursing home care. And yet there's currently very strict criteria that limit access to home support, so only those that need the most personal assistance can qualify. This limited access is a problem when a senior may be able to bathe herself, but needs day-to-day support of someone to cook a nutritious and tasty meal and avoid social isolation. But they can't because they don't meet the criteria for personal care. Often home support, when it is available, is provided by a parade of different people, when continuity of care, having the same person over time, is one of the most important factors in providing good care for seniors. Moving to Vancouver's nursing homes, we have the lowest number of direct care staffing hours per resident day in the province. So that's the combined number of registered nurses, LPN nurses, and care aide hours. And yet the research shows that staffing levels is a major determinant of quality of care. These low-tech, high human touch services are the ones most likely to make a difference to frail seniors' quality of life and quality of care. And it's these services that, if properly organized and supported, can help frail seniors stay out of hospital and avoid the many pitfalls of over-treatment. And yet, these are often the first services to be cut. So I'm just going to finish by giving you a quote from the World Health Organization, which states that a society that treats its most vulnerable members with compassion is a more just and caring society for all. And I'd like to conclude by asking us to work together in BC to build a system that treats frail seniors with the care and compassion they deserve. Thank you.